The present topic of discussion, it is on amyloidosis, wherein here we'll be discussing about its introduction, pathogenesis and the physical and chemical nature of amyloid, and then types of amyloid and classification of amyloidosis, and then we will also see about demonstration of amyloid. So these are the various topics we'll be discussing under this. So let's start with the introduction to amyloidosis. So basically, what is it, amyloid or amyloidosis? So it is actually an extracellular deposition of a fibrillar material, that is an abnormal fibrillar material. As you can see this in the present picture, that red areas, that is all is abnormal fibril which is deposited in the extracellular matrix. Okay, so this will be in the form of hyaline nature, which will be structureless. So now let's discuss what is it and where all it will be seen. So it is basically an extracellular deposit of abnormal fibrillar proteins, as we have discussed before. And this kind of fibrillar protein, because it is abnormal, right, it results in tissue damage as well as functional compromise. And this is basically seen in inherited as well as inflammatory disorders commonly. So familial and as well as inflammatory disorders, this amyloid deposition or abnormal fibrillar deposition is seen. From that time we have been telling abnormal fibrillar deposition. Okay, so what is it? How is it formed? How is this abnormal proteins are formed? How is this amyloid is formed? Okay, now let's discuss that. That is pathogenesis of amyloid is what we are going to discuss now. So first we'll see normalcy, how a protein is formed, then we'll discuss about how an amyloid is formed. So if we see in detail about protein synthesis, that is, this is a cell wherein protein synthesis is occurring. So wherein our protein synthesis includes transcription and translation, where the information is transferred from DNA to mRNA, as you can see in the picture, to its cytoplasm. So from the mRNA it will be transferred on to the ribosome, that is by translation. So that means here what happens, you can see here that amino acids will join together to form the protein. So if you see in this present picture, so we can see some ribosomes, right? So in this ribosome, wherein that spiral structure on top, that is the protein which is getting elongated, and you can see in the next sequence pictures wherein the folding is occurring. So basically, as the protein polypeptide formation is forming, they will even undergo folding, so that this protein folding is a physical process wherein it is going into its native state, that is its biological active state. Okay, so after the protein folding occurs, it will be released into the extracellular matrix. So if we are going back into our present picture, so there will be translation of this mRNA onto the ribosome, then protein is formed, and then this protein is undergoing folding. So this folded protein, later on some post-translational modifications will occur, and then it will be released into the extracellular matrix. So this is how normally it will occur. But sometimes even normally, this protein, there will be defects in the protein folding. Okay, so the folding will not occur properly. So that results in misfolded proteins. These misfolded proteins the cell will detect. Okay, if it is detecting in the cell, that is intracellularly, there are some organelles called as proteosomes. So those proteosomes, they will start to degrade them within the cell itself. But if sometimes they are not detected by proteosomes, even outside in the extracellular matrix, they will be considered as foreign bodies, and then they will be degraded by macrophages. Okay, so this is how normalcy will occur. But what happens sometimes, this degrading mechanisms, that is by proteosomes or by macrophages, where this will not occur. Okay, so when this doesn't occur, these misfolded proteins are nothing but abnormal proteins, right? So they'll start to get deposited extracellularly. So this extracellular deposition of misfolded proteins will occur, and these proteins will together they'll aggregate together to form fibrils. And these fibrils, one on top of another, it will aggregate later to form, giving rise to an amyloidosis. So basically what are these now? They are extracellular deposition of misfolded proteins wherein a defect will occur within the protein or within the degrading mechanism. So now let's see the history of our amyloidosis, that it was first described by Rokitansky in 1842, and in 1853 Virchow coined the term amyloid, wherein amyl means starch and oid means like, that means starch like material. Basically these are misfolded proteins, right? So they'll be insoluble, they are not soluble material. So these fibrils are insoluble, linear, rigid, and they measure around 7.5 to 10 nanometers in width. Okay, so now let's see about its characteristics, that is both physical and chemical nature of amyloid. So if we see physical nature, there are various forms of amyloid are there, okay, but physically all the forms of amyloid will appear identical, and this physical nature can be elicited by electron microscopy or by X-ray crystallography. So if you see under electron microscope, amyloid will appear as non-branching fibrils with a diameter of around 7.5 to 10 nanometers. Whereas under X-ray crystallography analysis and infrared spectroscopy, they will demonstrate a characteristic sheet pattern. Okay, so under X-ray crystallography and infrared spectroscopy, they will demonstrate a characteristic sheet formation which is beta pleated sheet formation, cross beta pleated sheet formation. So this is basically, we know that protein structure, it contains primary, secondary, tertiary and quaternary structure, right? Usually alpha helix and beta pleated sheets are in the secondary conformation. Okay, so this is how our amyloid will look, like a beta pleated sheets, that is one upon another. Okay, this is the physical nature of amyloid. Whereas chemical nature of amyloid, there are different forms and it is heterogeneous in nature. So each form of amyloid is different. Okay, so they are broadly divided into fibrillar and non-fibrillar. Okay, so of which 95% is fibril proteins and 5% is non-fibril proteins, which contains P component and some other glycoproteins. But what we are concerned about is that 95% of fibril proteins, where it contains 20 different forms of amyloid proteins, under which we are going to discuss the main important ones. So the first one is amyloid light chain protein, AL, that is. Next is AA, amyloid associated fibril. Next is A beta amyloid, then transthyretin, TTR, then beta 2 microglobulin. So these are the various important fibril proteins of amyloid. Now let's discuss each and everything. Okay, so first one is AL protein, which is also amyloid light chain protein. Light chains, heavy chains, where have you heard these? They are parts of immunoglobulins, right? So which immunoglobulins are deposited by plasma cells. So there is a defect in the plasma cells here, right? So if you see this flow chart here, some unknown etiology, okay, maybe it can be a carcinogen also, okay, which are resulting in monoclonal B lymphocyte proliferation. So whenever B lymphocytes proliferate, what is the terminally differentiated form of B lymphocyte? It is a plasma cell. So as plasma cells are getting proliferated, definitely immunoglobulins will be deposited, and here these are abnormal plasma cells, right? So whatever immunoglobulins will be deposited, they will also be abnormal, so they will not undergo degradation. So there will be very limited proteolysis resulting in amyloid protein formation, and the amyloid which is formed is AL protein, that is amyloid light chain protein, which is seen in plasma cells. Next we will see about amyloid associated fibril, AA, like that is seen in plasma cells. This is seen in liver cells, that is reticuloendothelial cells, and here the etiology is inflammation, inflammatory disorders. So here whenever there is a chronic inflammation, right, chronic inflammatory cells, the main one is macrophage. So whenever macrophages come into action, they will release some cytokines. That is how they elicit their defense mechanism, right? By releasing cytokines, that is interleukin 1 and 6. These interleukin 1 and 6, they will act on liver cells, that is reticuloendothelial cells. then these liver cells will deposit a protein called as SAA, serum amyloid associated protein. So this is a protein which is like, if you see normally, whenever this protein is deposited, by using some enzyme, this macrophage, it will break the SAA into some end products, that is, it is degraded by enzymes to end products. This is how normally it will occur. But sometimes what happens is that there will be a defect. So it can be an enzyme defect, that enzymes may not work properly, so SAA will get deposited, or there can be a defect itself in the SAA itself. So these enzyme defect or genetically abnormal SAA, they will not undergo degradation, right? So they'll start to get accumulated. So because of the limited proteolysis, they'll get accumulated, resulting in the formation of AA, that is amyloid associated fibril, which is formed by reticuloendothelial cells, that too in inflammatory disorders. Okay, next fibril protein is A beta amyloid. Actually this is seen in cerebral lesions of Alzheimer's disease. So in Alzheimer's disease, what happens is some cerebral plaques will be formed, and around the blood vessels also there will be amyloid deposits will be seen. So in the cerebral plaques as well as in the amyloid deposits around cerebral blood vessels, this A beta amyloid will be formed. So what is the main protein that is forming this A beta is a transmembrane glycoprotein. So this transmembrane glycoprotein is called as amyloid precursor protein, APP. So this amyloid precursor protein, it is resulting in the formation of A beta amyloid in Alzheimer's disease, cerebral lesion. Now next fibril protein is transthyretin, that is amyloid transthyretin, wherein it binds and transports thyroxine and retinol. So in the name itself it is a transports, T thyroxine thigh retinol ret, transthyretin. Okay, it is a normal serum protein which is seen in liver basically. Okay, so what happens is that whenever any mutations occurring in the genes producing transthyretin, okay, so mutations in genes encoding transthyretin, because of the mutations there will be alteration in the structure of this transthyretin. So as there is an alteration in the structure, it results in the formation of misfolded proteins. As misfolded proteins are formed, they get aggregated together, and they will become resistant to proteolysis, that is degradation. They will be resistant, resulting in the formation of amyloid, that is amyloid transthyretin. So these kind of amyloid deposit is basically, it results in diseases called as familial amyloid polyneuropathies. These are the diseases which show transthyretin. Okay, and sometimes this TTR is seen in some heart of aged persons also. So that results in amyloidosis called as senile systemic amyloidosis or senile cardiac amyloidosis. This is about transthyretin. Next and last one, that is beta 2 microglobulin. Okay, A beta 2 microglobulin, that is amyloid beta 2 microglobulin. Here what happens is, this is basically seen in high concentration in patients who are on long-term hemodialysis. So normal beta 2 microglobulin is there, that is a normal serum protein, and it's a component of MHC class 1 complex. Okay, so normal what happens is this serum protein, it will be filtered up by kidneys and it will be excreted in urine. But in case of hemodialysis patients, what happens is it will not be filtered through hemodialysis membrane. So as it is not filtered, it gets accumulated in the body, that is in the circulation itself. Accumulation resulting in high concentration of A beta 2 microglobulin in serum, resulting in amyloid formation. So it is seen in hemodialysis patients. So this is about chemical structure and forms of amyloid. Okay, now let's see classification of amyloidosis. What are the different types of amyloidosis are there? So basically classification, it is based on combined biochemical and clinical classification, where it is broadly divided into systemic or generalized and localized. So systemic, it involves several organ systems, whereas localized, only a single organ like heart, brain, like that they are affected. If you see systemic, if you see it on clinical grounds, it is subclassified into primary and secondary mainly. Okay, primary amyloidosis, secondary amyloidosis, and there's a third one called hereditary or familial amyloidosis, wherein it is actually a separate entity, but now we are discussing it under systemic or generalized one. Okay, let's discuss each one in detail. So firstly we'll see about primary systemic amyloidosis, wherein the main protein which will be deposited in primary amyloidosis is AL protein, that is light chain protein. So that means they are seen in plasma cell diseases, right? AL protein pathogenesis is plasma cell diseases. So where here in under primary amyloidosis, 30% of the amyloid cases are plasma cell dyscrasias, which are basically multiple myeloma, Waldenstrom's macroglobulinemia, heavy chain disease, solitary plasmacytoma, and B cell lymphoma. So all of these cases will have AL type of amyloid. Okay, so the 30% of them are plasma cell dyscrasias. So whereas 70% they doesn't have any proper etiology, we don't know from where these are forming. So that is why 70% of them are idiopathic in nature. So this is about primary systemic amyloidosis, which contains AL protein as the main amyloid protein. Next we'll move on to the secondary or reactive amyloidosis. Here the protein deposited, that is amyloid deposited, will be AA, amyloid associated. So AA will be seen in inflammatory diseases, right? Inflammatory disorders. So inflammation is seen in variety of cases. So firstly there are some infectious diseases which are inflammatory in nature, that is tuberculosis, chronic osteomyelitis, bronchiectasis, pyelonephritis, leprosy, chronic skin infections. In all these AA protein will be seen. And some non-infectious inflammatory diseases like that is rheumatoid arthritis, which is an autoimmune disorder, lupus erythematosus, inflammatory bowel disease. So these are some non-infectious chronic inflammatory diseases which show AA protein, and some tumors like renal cell carcinoma, Hodgkin's disease, and some inherited disorders like familial Mediterranean fever. So all these diseases or disorders, they will show amyloid associated protein. Okay, so these are all forms of secondary amyloidosis. Right? So now next we will see about hereditary or familial amyloidosis, which is also called heredofamilial amyloidosis. Name itself says, right, hereditary. So these are genetically determined amyloidosis, wherein the first one is hereditary polyneuropathic amyloidosis. We have discussed before only, and transthyretin, it is deposited in familial polyneuropathy. So here amyloid is deposited in peripheral and autonomic nerves, resulting in muscular weakness, pain, and paresthesia. And the type of protein deposited is transthyretin. And the next heredofamilial amyloidosis is familial Mediterranean fever. Amyloid in familial Mediterranean fever. Here the amyloid deposited is AA, amyloid associated, wherein here it is a fever, right? So periodic attacks of fever and polycirrhosis is seen. So these are various heredofamilial amyloidosis which are seen. Now let's see about localized amyloidosis, wherein a single organ will be defective, like amyloid will be associated with a single organ. First one is senile cardiac amyloidosis. Senile, older age group. Cardiac, it affects heart. So it is seen in elderly age group, and deposits are seen in heart and aorta. And the type of protein seen is transthyretin. Next is senile cerebral amyloidosis, wherein A beta amyloid is the main one which is seen, and also we can see amyloid prion protein also we can see. So this is basically cerebral amyloidosis seen in Alzheimer's, Down syndrome and all. Next is endocrine amyloidosis, that is hormone precursors will be there, wherein this is seen in medullary carcinoma of thyroid, islet cell tumors of pancreases, type 2 diabetes mellitus, it is very important. So corneal amyloidosis. So these are all various endocrine amyloidosis, and this is the classification of amyloidosis. Now let's see how to demonstrate amyloid See, whenever you see it under some H&E stain section, you might get confused by saying amyloid to collagen or something. Okay, so how do we demonstrate? So if you see H&E stain section, amyloid will be seen as extracellular material which is homogeneous, as you can see in the picture, homogeneous in nature, structureless also, and it will be eosinophilic in color, and it's a hyaline material, and most of the time it will be present in relation to blood vessels. So it is a structureless and eosinophilic hyaline material and homogeneous in nature, seen in relation to, most of the time in relation to blood vessels. So if at all, if you are not able to see, differentiate it in H&E stain section, we can use some special stains like Congo red stain here. So this is a picture here of Congo red stain of amyloid, wherein amyloid has an affinity for Congo red. It shows pink red color. So you can see that pink red color, right? So next is under polarizing microscopy also you can observe, you can identify amyloid. That is, you can stain with Congo red itself. If you see on the left, that pink areas, that is amyloid. But if you are not able to demonstrate, you can see the same thing under polarizing microscopy, wherein amyloid will show apple green birefringence. Apple green in color. So you can see that color, right? Apple green birefringence is because of the beta pleated sheet configuration of the amyloid fibrils. Okay. And other than polarizing microscopy, we can also use fluorescent microscopy using fluorescent stains like thioflavin T, wherein amyloid will start to fluoresce in yellow color under ultraviolet light. As you can see here, that yellow deposit, whatever is there, that is amyloid. Other than this polarizing and fluorescent, we can even use some metachromatic stains, which are nothing but rose aniline dyes. So commonest ones are methyl violet and crystal violet. They impart rose pink coloration to amyloid deposits. So amyloid will appear in the form of rose pink coloration. So these are the various staining characteristics of amyloid. That is how we demonstrate amyloid. So this is in detail about amyloid, wherein we have seen what is the introduction to amyloid and then pathogenesis of amyloid. That is, it is formed by extracellular deposition of misfolded proteins, and these are insoluble in nature. And we have even seen physical and chemical nature of amyloid, wherein different forms of amyloid are there chemically. So like AA, AL and all. So depending upon the type of amyloid present also, we can determine the disease. So like that, we have seen classification of amyloidosis, wherein primary, secondary and heredofamilial amyloidosis is there, localized amyloidosis is there. And then we have seen special stains which are there to demonstrate amyloid. So this is in detail about amyloidosis.